Let's start our ectopic pregnancy. This topic is the first topic of early pregnancy care, which will be having almost 5 to 6 lectures, and after that we will do the MCQs I've collected from different books. I think 14 to 50 MCQ books material is there in that one single lecture, inshallah, coming soon. So starting with the ectopic pregnancies, it's 2016 BJOG guidelines, RCOG guidelines. Nothing has been changed much since 2016. It's been, I think, 9 years we are following this guideline since then. So the incidence, first of all, we are going to see. So the incidence is, it is 11 in 1000 pregnancies. It means it's 1.1%. Each year 11,000 ectopic pregnancies are being diagnosed. Okay, it is estimate, it is just an estimate that 11,000 ectopic pregnancies are diagnosed each year. So the incidence is 1.1%. So in the early pregnancy units, the woman attending with the ectopic pregnancy, the incidence is 2 to 3%. So whenever the incidence do come in our exams, what are we going to do? We are going to, this is 2 to 3%. Okay. Risk factors: tubal damage following surgery. Tubal damage following surgery. Okay, it could be surgery due to the endometriosis, it could be surgery due to the ovarian cyst, adnexal mass, any of the surgery that was related to the fallopian tubes. It must have caused damage because there must be some scarring, there must be some fibrous tissue, and the embryo was not able to travel from the fallopian tubes into the uterine cavity and get implanted over there. Okay, then the smoking, IVF. There are also few more factors, which is intrauterine contraceptive device, and the history of diethylstilbestrol exposure in the pregnancy. There are all the risk factors associated with this guideline. Now I've jumped directly to the details. I'm not just going through the executive summary. Okay, so the ultrasound criteria. First of all, we are going to discuss this tubal pregnancy. How is this diagnosed? All the ectopic pregnancies are diagnosed by the ultrasound criteria, and there is a biochemical investigation, and then we manage it. Okay, in management comes the different techniques, whatever suits that ectopic pregnancy. So ultrasound criteria: TVS, transvaginal ultrasound, is actually the diagnostic tool of choice for tubal ectopic pregnancy. Tubal ectopic pregnancy should be positively identified, if possible, by visualizing an adnexal mass that moves separate to the ovary. So whenever in a TVS, patient has come to you with UPT positive, and in TVS you are visualizing an adnexal mass moving separate to the ovary, that's definitely ectopic pregnancy, because this transvaginal ultrasound TVS has very high specificity. Look, 94 to 99.9%, and the sensitivity is 87 to 99% for the diagnosis of ectopic pregnancy. So that is ectopic pregnancy in the TVS, whenever you see an adnexal mass that moving separate to the ovary. Laparoscopy is no longer the gold standard anymore. Okay, so TVS is the diagnostic tool. I'll start from this 20% thing, which is the pseudo-sac, and then we'll step up to the percentages that goes up to the 60%, just to memorize in a very good way. 20% is the incidence of the pseudo-sac. In 20% of the cases, we see a collection of the fluid within the uterine cavity. And do you know what is this collection of fluid? Where does it comes? Where does it comes from? It comes from the intrauterine pregnancy. Okay, it comes from an early sac, early gestational sac. So the collection of the fluid may be seen within the uterine cavity. So in 20% of the cases, it is called the pseudo-sac. Now you have to distinguish it from the early intrauterine gestational sac. Okay, it may only be a collection of fluid within the uterine cavity, but it could be an early intrauterine gestational sac. So we distinguish it by two signs. It's the intradecidual sign and the double decidual sign. They both signs are for early intrauterine pregnancy. In the intradecidual sign, there is an echogenic rim in which there is a fluid collection, and that rim is located within a markedly thickened decidua on one side of the uterine cavity. Okay, because sac is implanted into the uterine cavity. echogenic rim with a fluid collection located within a markedly thickened decidua on one side of the uterine cavity. It is an intradecidual sign within the decidua. And the double decidual sign is the two concentric echogenic rings are surrounding an intrauterine fluid collection. Okay, so intradecidual sign, double decidual sign, these two signs are for an intrauterine early pregnancy, and we distinguish it from the pseudosac, that is just a collection of fluid. There is no rim in it, okay, within the uterine cavity, and it is present only in 20% of the cases, pseudosac. In 15 to 20% of the cases, there is an extrauterine gestational sac, and its location could be anywhere in the interstitium, in the ampullary region, in the tube, anywhere. We'll discuss further that what could be the location of the, at different levels of the fallopian tube, what could be the location of the ectopic pregnancy. So the extrauterine gestational sac with yolk sac or the fetal pole may or may not have an FCA present. It's 15 to 20% of the cases, and 20 to 40% of the cases there's an empty extrauterine gestational sac, no gestation sac, no fetal pole, there's no point of the FCA then. Okay, it's 20 to 40% which is empty. Now 50 to 60%, this is the most common finding. It is inhomogeneous non-cystic adnexal mass. Inhomogeneous non-cystic adnexal mass, okay, that you see separated to the ovary, and it's 50 to 60%. Now a woman has come to you with a positive pregnancy test, and you have in TVS intrauterine smooth walled and echoic cystic structure, but intrauterine smooth walled and echoic cystic structure, no adnexal mass. So this is 99.98% intrauterine pregnancy. There's only 0.02%, which is almost negligible probability of an ectopic pregnancy. Okay, so echogenic fluid, it's reported in 28 to 56% of the ectopic pregnancy. So it is basically due to the tubal rupture. Whenever there is a tubal rupture, we'll see the echogenic fluid. Okay, and this anechoic fluid is seen in the pouch of Douglas, may be found in both the intrauterine and ectopic pregnancies, because sac is releasing this fluid. Echogenic fluid, it is most of the small amount of the anechoic fluid in the POD may be found in both, but echogenic fluid is seen in the ectopic pregnancies. Okay, and it signifies tubal rupture, but most commonly it is due to the blood leaking from the femoral end of the fallopian tubes. Serum progesterone level, it has no role now in predicting ectopic pregnancy. Beta HCG is serum beta HCG levels are very important, because we plan the management of the ultrasound visualized ectopic pregnancy according to it. Whenever beta HCG levels are less than 1000, it means ectopic pregnancy is unlikely. Okay, there is also a thing called pregnancy of unknown location. We'll talk about it at the end of this lecture. The initial serum beta HCG level, it is a key prognostic indicator for the success of the conservative method management, because when we are managing the patient, either that management is conservative, medical, surgical, we always do the follow-up, we do the monitoring of the pregnancy with the beta HCG levels. Either the levels are falling down, it's increasing, and what's the pattern of that increase, what's the pattern of that decrease. Okay, I'll now directly jump to its management, so to wind up our ectopic pregnancy. Okay, laparoscopic surgical approach is always preferred. Okay, laparoscopic surgical approach is always preferred. Whenever the patient is stable, you have to go for the laparoscopic surgical approach. Okay, now what are the scenarios in which you are going to decide either we have to go for salpingectomy or the salpingotomy? Now, if the patient has a healthy contralateral tube, the other side of the tube is very healthy, and there is no history of fertility reducing factors, you will remove the tube, because the recurrence rate of ectopic pregnancy is very high in the affected tube. Okay, whether that effect is due to the surgery, because there has been insult of the tube in the form of an ectopic pregnancy. There would be a scarring, there would be fibrous tissue, and patient becomes more prone to the ectopic pregnancy next time again. There would be the recurrence rate higher on the higher side in the subsequent pregnancies. Okay, if the other side of the tube is healthy, because the patient will conceive with a healthy tube, with a healthy contralateral tube, we'll go towards self-injectomy. We'll remove the tube. And if there are fertility reducing factors, patient already has a history of ectopic pregnancy, contralateral tubal damage is there, previous abdominal surgery, history of previous abdominal surgery, either that's appendicectomy, either that's any of the surgery in which there has been the manipulation of the tube, or the previous PID. Patient has history of infections, recurrent, on and off, we'll go for self-injotomy. We're going to save the tube. Okay, self-injectomy for the healthy contralateral tube, and self-injotomy for the unhealthy tube, unhealthy contralateral tube. But in the self-injotomy, there is a risk of the persistent trophoblast, and we need to follow it, we need to monitor it with serum beta HCG levels. If self-injotomy is performed, women should be informed about the risk of the persistent trophoblast. So what's the risk of the persistent trophoblast? It's 7%. 3.9 to 11% is written, but we round it off, it's 7%. 7% risk of persistent trophoblast with self-injotomy, and with self-injectomy it's less than 1%. Okay, with self-injotomy, the drawback is that patient has a risk of persistent trophoblast. It's 7%. So patient should be proper counseled about it, that they may need further treatment in the form of the systemic metho or self-injectomy. Okay, systemic metho. So this is pharmacological management. It is always offered to the suitable patient. There is a selection criteria we'll just discuss in some time. Systemic metho is always offered to the suitable patient with a tubal ectopic pregnancy. It is never given at the first visit unless the diagnosis of ectopic pregnancy is absolutely clear, and we have excluded the viable intrauterine pregnancy. Okay, there are two things. We are sure about the diagnosis of the ectopic pregnancy, and we have excluded that there is no viable intrauterine pregnancy. Okay, and the expectant management is again for the clinically stable women who have ultrasound diagnosis of ectopic pregnancy and beta HCG levels are less than 1500. Let's discuss the rates, different incidences in different rates. Now we have already discussed that this is the 7%. Okay, self-injotomy group has 7% risk of persistent trophoblast, and in self-injotomy the pregnancy rate. Now there are two pregnancy rates. When in exam it comes like cumulative ongoing pregnancy. This is cumulative ongoing pregnancy rate. This is the cumulative ongoing pregnancy rate. It is 60% in self-injotomy group, and self-injectomy it is 50%. It has reduced somehow, ongoing risk. But when there is a question in which they are asking you regarding subsequent intrauterine pregnancy rate. Now this cumulative ongoing pregnancy rate, we're not sure about this pregnancy, either it's intrauterine or it's extrauterine. Okay, so cumulative ongoing pregnancy rate after self-injotomy is 60%. Self-injectomy is 56%, but subsequent intrauterine pregnancy rate is 75% after self-injotomy and 40% after self-injectomy. Okay, 60 cumulative ongoing pregnancy rate, 75% subsequent pregnancy intrauterine pregnancy rate, 56.2 after self-injectomy cumulative ongoing pregnancy rate, and 40% subsequent intrauterine pregnancy rate. Now repeat ectopic pregnancy, recurrence rate of the ectopic pregnancy is 8% in the self-injotomy group and 5% in the self-injectomy group. Okay, recurrence ectopic pregnancy is 8 and 5%. Okay, you can make a table so that you can memorize it in a better way. So this is what I have told you. Subsequent intrauterine pregnancy rate were greater than 90% in both the groups in the women with no fertility reducing factors. Okay. Now, women undergoing salpingotomy have a serum beta HCG levels taken 7 days after surgery. So, women undergoing salpingotomy have a serum beta HCG levels taken 7 days after surgery and then weekly until the negative. This is the how we do the follow-up after doing the salpingotomy. After salpingotomy, beta HCG level after 1 week of the surgery and then weekly until the negative result. This was the persistent trophoblastic rate I told you. It's round off 7%, 3.9 to 11% after salpingotomy. So, what are the factors that increase the risk of the persistent trophoblast? It is that high pre-operatively beta HCG levels were very high, and pre-operatively there was the rapid rise in the beta HCG levels and the tubal mass is very large. These are the things which are the risk factors, 3 risk factors: high preoperative levels, rapid rise in serum beta HCG. Let's start our metho management. So it is given at a dose of 50 milligram per meter square. It is given in a single dose. And prophylactic metho at the time of the laparoscopic salpingotomy has also been reported. Okay, and there is a significant reduction in the rate of the persistent trophoblast when prophylactic metho is being done. This is a very beautiful point. I must highlight it. So, the use of the prophylactic metho at the time of the laparoscopic salpingotomy. It will reduce the rate of the persistent trophoblast from 14.5% to 1.9%. Okay, it will reduce from 14 to 2% almost. So, metho can be given in the multiple dose regime. It is most commonly given as a single IM. It is an IM injection, 50 milligram per meter square, and then we measure the beta HCG levels on the day 4 and day 7 post metho. You have given the IM single dose metho 50 mg per meter square. Now on the day 4 and day 7, what are we going to do? We are going to monitor the beta HCG levels. And if those levels increase, if the beta HCG level is decreasing more than 15%, okay, day 4, day 7 post metho beta HCG level measured. Now, if the reduction is more than 15%, then we will weekly measure it until the beta HCG levels are less than 15 international unit per liter. And if it is not decreasing by 15%, then we will repeat the TVS, because we now have to exclude the FCA and the hemoperitoneum, either it's there or not, after the single shot of metho, why the levels are not going down. So 15% is the criteria. It should decrease more than 15%, and if it is not decreasing, then with TVS we'll figure it out. Now the single dose metho, it has a success rate of 65 to 95%. 65 to 95%. And 3 to 27% of the women are still there who require a second dose. So overall, when in exams they ask you regarding the success rate of metho, it is 90.7%. Okay, 90.7% is the basically success rate of metho. There are a number of predictors of success of this metho treatment. Basically, there are 4 things. Okay, we'll discuss one by one. Number 1, initial serum beta HCG levels. If it was less than 1000, then success rate is 98%. And if it is more than 5000, then it reduces to about 38%. Okay, less than 1000, 98% success rate of the metho. But when they are more than 5000, then there is no point of metho. That's the reason when the levels are more than 5000, we go for surgical management. We do not manage it pharmacologically. Okay, because it's 38% success rate. Ultrasound appearance of the ectopic pregnancy. If there is no gestational sac, no fetal pole, no FCA, there would be a high success rate. Number 3, pre-treatment changes in the serum beta HCG. If the pre-treatment changes means the beta HCG was rising up to 11 to 20% over 48 hours prior metho. After 48 hours, you look upon the levels of the beta HCG, how are they multiplying? If it is intrauterine, they double and triple, and every 48 hours they double. But here, over 48 hours, if the beta HCG increases up to 11 to 20% over 48 hours, then the success rate would be high. Now, beta HCG levels on day 1 and day 4 after metho, which we said that it should decrease more than 15%. So it is decreasing levels, then the success rate is 88 to 100%. Okay, if the levels are rising, then the success rate is very low. It's of not significance. You should avoid alcohol and folate containing vitamins with the metho treatment because it has an anti-folate action. The adverse effects are bone marrow suppression, pulmonary fibrosis, non-specific pneumonitis, liver cirrhosis, renal failure, gastric ulceration, excessive flatulence, bloating, transient mild increase in LFTs, stomatitis. These are all the adverse effects of the metho. There are also some most common side effects, which are these: flatulence, bloating, mild elevation of the LFTs, stomatitis. They are more common, basically, more common adverse effects. And these are very lethal adverse effects. They are basically the complication of this drug. So the contraindications of the drug. What are the contraindications of the drugs? The contraindication of the drug is, we are looking at this, that it causes bone marrow suppression, pulmonary fibrosis, no specific pneumonitis, liver, renal. So it is basically hepatotoxic, it is nephrotoxic, it is not gastric friendly, it is not lung friendly, it is not bone marrow friendly. So the patient who is hemodynamically unstable, intrauterine pregnancy, breastfeeding, who is not ready for the compliance, CLD, pre-existing blood dysuриas, non-sensitivity to the metho, active pulmonary disease, immunodeficiency, and peptic ulcer disease. These all are the contraindications to the metho. Now, who is a good candidate? Who is hemodynamically stable? Beta HCG level is less than 1500, but it should not be more than 5000. No FCA, no intrauterine pregnancy, willingness to attend for the follow-up, and no non-sensitivity to the metho. So it should be the first line management for the patients who are ready to go for the follow-up, who are ready for the compliance of the treatment. So what's the criteria of giving metho? There should be no pain, ectopic pregnancy must be unruptured, and the mass should be less than 3.5 centimeter or 35 millimeter. There should be no FCA, beta HCG levels between 1500 and 5000, and no intrauterine pregnancy. Okay. So if these all things are beta HCG level between 1500 to 5000, less than 3.5 centimeter of this unruptured ectopic pregnancy, no FCA, no pain, no intrauterine pregnancy. Okay, the patient is ready for the metho. Now moving towards the expectant management. What is its criteria? We have seen that the success rate of the metho is 90.7% overall, and it is first line. Now what about the expectant management? Its success rate is 57 to 100%, and it is inversely proportional to the beta HCG levels. Higher the levels, success rate would be low. So this is very good thing. Beta HCG levels starting from 175 to 2000. What would be the success rate of the expectant management? Because after 2000, we're not going to manage it conservatively. Expectant management has no role in it. So beta HCG levels less than 175, 96% success rate, very high. And when beta HCG levels are more than 175 to 1500, it's 66%. it has reduced drastically success rate. Less than 1000 success rate is 80 to 90%, and less than 2000 60 to 67%. So it means less than 175 international unit per liter beta hCG levels are less than 175, 96% success rate. Less than 1000, 80 to 90% success rate. Okay, 80 to 90 and 96%. These two things must be remembered. Now, what's the selection criteria for the ectopic pregnancy? Patient should be stable, no pain, ultrasound should have no FCA, no hemoperitoneum, and ectopic pregnancy should be less than 3 cm. For metho, it was 3.5 cm or 35 mm, but for expectant management, it is 30 mm or 3 cm. And beta hCG levels should be less than 1500. From 1500 to 5000, we are going to manage it medically, but less than 1500, we are going to go for expectant management. Then we will follow up the pregnancy till the beta hCG levels are less than 20. Okay, and we'll repeat the beta hCG levels between 2 to 7 days. Within a week, we have to repeat from day 2 to day 7. Now, if the beta hCG levels are suddenly rising, there is a pain, beta hCG levels have jumped to more than 2000, you are going to discontinue the treatment. There is also a good thing, which is beta hCG ratio less than 0.8. What's this ratio? It is basically pre-treatment beta hCG ratio. It is also going to predict the success rate of the expectant management. So expectant management is, because it is inversely proportional to the beta hCG, so serum beta hCG levels at 0 hours and then at 48 hours. We're going to divide it and we'll get the ratio. Pre-treatment beta hCG ratio less than 0.7, 72% would be the success rate. Okay, less than 0.7, 0.8, 72% would be the success rate. So metho success rate 90.7% and expectant management success rate is 72% if the pre-treatment beta hCG ratio is less than 0.8. This is written over here. Moving on to the cervical pregnancy. Now, how are we going to diagnose this cervical pregnancy that's laying within the cervix? So it is very, very rare and less than 1% of all the ectopic pregnancies. Okay, its incidence is less than 1% of all the ectopic pregnancies. I'm going to compare cervical pregnancy with the cesarean scar pregnancy. Okay, I'm going to compare the cervical pregnancy with the cesarean scar pregnancy, okay, because they have so many things in common and there is a very little difference between both of them while diagnosing, because cesarean scar pregnancy is also laying down in the lower segment of the uterus, and cervical pregnancy is there in the cervix. They are very close to each other, and when we visualize it with ultrasound, there are different criteria by which we diagnose either it's cervical or a cesarean scar pregnancy. Okay, so its incidence, cervical pregnancy less than 1% of the incidence. So if we make a pentagon like this, okay, in the pentagon, on one end, number 1 point is the empty uterine cavity. In cervical pregnancy, in cesarean scar pregnancy, both have empty uterine cavity. Okay, cervical scar pregnancy. Second point is barrel shaped cervix. Number 2, barrel shaped cervix. Number 3, gestational sac is present below the level of the internal cervical os. Okay, sliding sign is absent. The gestational sac present in case of the cervical pregnancy, it is present below the level of the internal cervical os, and when we talk about the cesarean scar pregnancy, this gestational sac is located anteriorly at the level of the internal os, and it is embedded at the previous lower segment cesarean scar. Okay, so in cervical scar, in cervical pregnancy, the absence of the sliding sign. What is this sliding sign? Do you know what is the sliding sign? Okay, sliding sign is because So it is difficult to differentiate between the cervical pregnancy and RPOCs of the miscarriage, missed miscarriage, or incomplete miscarriage, and we differentiate it with the sliding sign. And sliding sign is when we trans vaginal probe is with the gentle palpation we move the pregnancy. There is it slides, okay, the whole mass slides. So in this case, cervical pregnancy, definitely if the whole cervical pregnancy is implanted into the cervix, so it is stuck to it, so there would be absent sliding sign. Okay, when the pressure is applied to the cervix using the probe, in the miscarriage, what happens is that the sac slides against the endocervical wall because it is not implanted in the cervical pregnancy. Na? The gestational sac is not implanted. But in this case, gestational sac is implanted, so it will not slide against the endocervical canal. Blood flow around the gestational sac can be determined using the color Doppler. Okay, if the gestational sac, the blood flow, then FCA can be differentiated whether FCA is positive or not. So these are the 5 points. Empty uterine cavity, barrel-shaped cervix, sac present below the level of the internal cervical os, sliding sign absent, and blood flow around the gestational sac using the color Doppler. And what about when we talk about cesarean scar pregnancy? In the cesarean scar pregnancy, what happens is ultrasound, we sometimes with the transvaginal scan, we also supplement it with the transabdominal imaging, and MRI is also used in the cesarean scar pregnancy. Okay, there are two modalities. It is a second line investigation, and the prevalence is 1 in 2000. Now, 5 ultrasound diagnostic criteria: empty uterine sac, gestational sac located anteriorly at the level of the cervical os because it is embedded at the site of the previous scar, thin or absent layer of the myometrium, okay, because it is implanted over there. So either the myometrium layer would be very thin or it would be absent between the gestational sac and the bladder. This is a very important point. Trophoblastic circulation can be visualized on the Doppler examination, either that's prominent or not. Definitely FCA we can see over it, and the empty endocervical canal. Okay, empty endocervical canal in cervical pregnancy, it wasn't empty because it was cervical pregnancy. So empty uterine cavity, empty endocervical canal, sac located anteriorly at the level of the internal os, thin or absent layer of myometrium between the gestational sac, and two things, basically two things are very common: empty uterine sac and the evidence of the prominent trophoblastic or the placental circulation can be seen on the Doppler examination. Okay, when we talk about the criteria of cervical pregnancy, the beta HCG levels, if in cervical pregnancy, if the beta HCG levels are more than 10,000, there is no role of metho. Okay, you are not going to give metho. There would be, the treatment will get failed. Okay, so beta HCG levels are carried out at diagnosis. Single beta HCG level is carried out in diagnosis, and in cesarean scar pregnancy there is no role of biochemical investigations. Okay, now we'll move towards the, now there are two different types of the cesarean scar pregnancy. How the gestational sac, once it has developed, how the pregnancy is progressing towards the uterus. Either it's progressing, the type 1 is when it's progressing into the uterine cavity, and gestational sac will grow, develop, and it will have the potential to reach to the viable gestational age if it progress into the uterine cavity. Okay, but there would definitely be a risk of risk of hemorrhage from the implantation site, but it can reach to the viable gestational age because it is progressing into the uterine cavity. In the second one is not going to progress. Pregnancy is not going to progress because it will progress deeper towards the serosal surface of the uterus. So there would be the first trimester rupture or hemorrhage, and that would be an emergency. Okay. Now cervical pregnancy, how are we going to manage it? Medical management has a very beautiful role in cervical pregnancy. Okay. Metho can be managed, can manage this cervical pregnancy. It's the medical management. So surgical management is only reserved for the women suffering life-threatening bleeding, and it has a very high failure rate. Okay, so what are its success rate of the metho is 91% in the cervical pregnancy. Okay, so um, gestational age less than 12 weeks, no FCA, and very low beta hCG levels. They are associated with the increased success rate of conservative management. But the failure rate would be increased if gestational age is more than 9 weeks, FCA is present, CRL is more than 1 centimeter or 10 millimeter, beta hCG levels are more than 10,000, then it's a straight away no. The failure rate is very high with the metho. Okay, so success rate is 91%. Successful cases also require surgical debulking or the local injection with the metho in addition to the systemic therapy. So you have to go for local injection of the metho with the systemic therapy, or you have to go after metho, you can do the surgical debulking with the systemic metho. Okay, both these cases are associated with a very good success rate. There is also another option, which is that systemic metho. With systemic metho, you can intraamniotic injection or the intracervical injection can be given. But what happens in these situations? There is a high rate of complications: infection, uterine infarction, sciatic nerve injury, necrosis of the bladder and the rectum, because intracervical and systemic metho is when combined with this, there would be disaster with the uterine arterial ligation and the uterine artery embolization. Okay, so DNC is a straight no. We are not going to go for this because it is a very high risk of hemorrhage. In case of the cesarean scar pregnancy, first trimester cesarean scar pregnancy is managed with medical and surgical intervention, and hemostatic measures are also added with it. Okay, so patient should be counseled that this is associated with the very severe maternal mortality and morbidity. Medical surgical interventions with and without additional hemostatic measures should be considered with the first trimester cesarean scar pregnancy. Okay, if it's first trimester, we'll consider all these things: medical management, surgical management, and definitely when we are doing surgically managing the patient, we'll have to go for the hemostatic measures. So there is not any one specific intervention. There is no evidence of one good over the other, but literature supports surgical management, which is more effective as compared to the medical management in case of the cesarean. So this is the main difference. Cervical pregnancy, metho has a very good success rate, and in cesarean scar pregnancy, surgical approach is more effective. Okay, so this surgical approach can be managed. Okay, let's talk about the surgical approach. How many options do we have? Number one is that surgical approach, we can combine it with the cervical cerclage, and if we are going for the suction and evacuation, okay, then we can combine it with cervical cerclage, Foley's catheter, and uterine artery embolization as an additional hemostatic measure. This is the one surgical approach, which is a suction and evacuation, combining with all these things. The other is the hysteroscopic resection. Okay, the other one is the hysteroscopic resection, and the third one is the excision. And excision can be done either by open, laparoscopic and transvaginal approach, and it has an advantage while excising this cesarean scar pregnancy. While doing the excision, we can also repair the scar with it. so it's good. Suction and evacuation with metho. When suction and evacuation is done with metho, it will have the reduced risk of hemorrhage, and there will be more quick resolution. There is also an option of the expectant management for small non-viable scar pregnancies, and if the pregnancy is partially implanted into the scar and grows into the uterine cavity, which was the type 1, which can reach up to the viable gestational age, then we can consider this expectant management. However, second trimester cesarean scar pregnancy is very high risk of maternal morbidity, and it will lead to the hysterectomy. Okay, this is all about cervical pregnancy and cesarean scar pregnancy. Okay, now just like we compared the cervical pregnancy with the cesarean scar pregnancy, now we are going to compare two more type of ectopic pregnancies, which is the interstitial and corneal pregnancy. They both are also more or less same with few differences, and we can, in order to memorize it and to keep it in our memory for a long time, we're going to compare both of these and we're going to study side by side. Now, interstitial pregnancy, its incidence is 1 to 6% of the ectopic pregnancy. So 1 to 2 centimeter, basically interstitial portion is the 1 to 2 centimeter its length, okay, and it traverses the muscular myometrium of the uterine wall, opening through the tubal ostium into the uterine cavity. It traverses interstitial part, traverses the muscular myometrium of the uterine wall and opening through the tubal ostium into the uterine cavity. Okay, so now we are going to, in cesarean scar pregnancy and in cervical pregnancy, we made a pentagons because there were 5 diagnostic ultrasound criteria. Over here there are 3 ultrasound diagnostic criteria. Now we are going to make triangle. Now, number 1, empty uterine cavity. Okay, empty uterine cavity. Number 2, products of conception or the gestational sac is located laterally in the interstitial portion or the intramural part of the tube. Products of conception, number 1, empty uterine cavity. Number 2, products of conception in the gestational sac is located laterally in the interstitial or the intramural part of the tube. This is, and it is surrounded by less than 5 mm of the myometrium in all the imaging planes. This is very important because it's going to make the difference. And third point is interstitial line sign. Interstitial line, what is this interstitial line? This is basically a thin echogenic line which is extending from the central uterine cavity echo to the periphery of the interstitial sac. Basically, the interstitial sac is connecting to the central uterine cavity through this thin echogenic line. So it is significant for interstitial pregnancy because it has 80% of the sensitivity and 98% specificity. This interstitial line sign has a very high specificity. Okay, so MRI. In the cesarean scar pregnancy, we had an MRI which was second diagnostic tool, and over here we are also going to take help from the MRI because interstitial line sign we are going to see on the TVS or on the ultrasound TVS or the transabdominal in both of these scans, but in MRI we are going to see the endomyometrial junction. It is the intact junctional zone. And what is this intact junctional zone or the endomyometrial junction? It is actually present a zone that is present between the uterine cavity and the gestational sac. Okay, and it is gestational sac is seen lateral to the cornua surrounded by the myometrium. It is on MRI what we are going to see. Okay, empty uterine cavity, products of conception laterally in the interstitial part of the tube and surrounded by less than 5 mm of the myometrium. And interstitial line sign, number 3. Okay, these 3 are the diagnostic criteria. And as far as beta ECG is concerned, biochemical investigations have very important role in both of these ectopic pregnancies because in 48 hours when we repeat the serum beta ECG, we are going to decide the further management, that what it should be. Now moving on to the corneal pregnancy, the ultrasound criteria, it is What is corneal pregnancy? Corneal pregnancy is actually implantation in the congenitally abnormal, C for cornua and C for congenitally abnormal uterus. Okay, it get implants into the, when the pregnancy gets its implant in the congenitally abnormal uterus in one horn of the bicornuate uterus or the one lateral half of the uterus of the bifertility, then we called it a cornual pregnancy. Now, it is, incidence is 1 in 76,000. Okay, incidence is 1 in 76. Cornual pregnancy has an incidence of 1 in 76,000, and in a triangle we are going to discuss each of the corner. Number 1, single interstitial portion of the fallopian tube is in the main uterine body. Okay, visualization of the single interstitial portion of the fallopian tube in the main uterine body. Number 2, this is the thing that's uh, that that is making difference from the interstitial pregnancy. Okay, this is the interstitial portion of the fallopian tube in the main uterine body, and here it is, products of conception are mobile and separate from the uterus, and they're completely surrounded by the myometrium. In interstitial pregnancy, it was located laterally in the interstitial part of the tube. It wasn't mobile and separate, it was located laterally in the interstitial part of the tube, and it was surrounded by less than 5 millimeter of the myometrium. But over here, what is, it is completely separate and mobile from the uterus and surrounded by the myometrium completely. Number 3 is the vascular pedicle, which is adjoining the gestational sac to the unicornuate uterus. So this vascular pedicle is also different. There was an interstitial sign but in the interstitial pregnancy, but in corneal pregnancy there is a vascular pedicle adjoining the gestational sac to the unicornuate uterus. And biochemical investigation, again you have to repeat the serum beta hCG in 48 hours because it's same in both these pregnancy. Now moving on to the management. In the interstitial pregnancy, management is, actually the management depends on the clinical presentation of the patient, size of the interstitial pregnancy, FCA present or not, and the serum beta hCG levels. Okay, these 4 are the things on which whole of the management depends: clinical presentation, size of the pregnancy, FCA, and serum beta hCG. Okay, now if the patient is stable, for the stable patients with interstitial pregnancy, non-surgical management. Okay, and expectant management, if the beta hCG levels are very low, significantly reduced beta hCG levels, and in whom metho will not improve the outcome, we are going to go for expectant management. Now metho and surgical management, they both have a very effective role in interstitial pregnancy. Metho has a success rate of 91%, and surgical management can be by laparoscopic or hysteroscopically, but in both these techniques, what are we going to do? We are going to do the resection, corneal resection, or the salpingotomy can be done. Okay, if we are hysteroscopically doing the corneal resection, then we will go for laparoscopic and ultrasound guided approach. Okay, beautiful thing regarding the surgical management is they have told us 2 different ways, but in both different ways we are going for corneal resection. But in this metho, how are we going to give the metho? There are 2 different methods, and both these methods have the same success rate, which is 91%. Okay, one is that single dose IV metho is given and oral folic acid rescue regime is given. So okay, this is only the metho, how we give it: IV metho single dose and oral folic acid. And second is that TVS guided aspiration of the exocoelomic fluid is done from the gestational sac. Okay, TVS guided aspiration of the exocoelomic fluid from the gestational sac, followed by the intracerebral injection of 25 mg metho and it is uh, it depends you want to give KCL or not. It is embryo-seeded. zero point 0.2 to zero point 0.4 milliequivalent KCL can be given with 25 mg of the metho given intracelularly, okay, after TVS guided aspiration of the exoslomic fluid from the gestational sac. Okay, so these both are the methods of the pharmacological management, how we are gonna give metho to the patient, and both have the similar success rate, which is 91%. Okay, in the interstitial pregnancy, we always go for hemostatic suturing technique. Okay, you just listen to me, because whatever I'm telling you, it's all written over here. Okay, there are 5 techniques basically. In number 1 is the laparoscopic resection is done with a purse string technique. Purse string technique. Okay, we are going to go for the laparoscopic resection with purse string technique. Number 2, during laparoscopic surgery, how are we going to secure hemostasis? Very beautifully this whole thing is written in, and I'll tell you in simple words. You have to take 1000 ml normal saline, okay, and you are going to put 1 ampule of vasopressin, which is 20 units. 1 ampule of vasopressin has 20 units of vasopressin in it. Okay, you are going to administer that whole 1 ampule into the 1000 ml of the normal saline. Now it has got diluted. Now you're going to take 150 to 250 ml out of it, which is the diluted vasopressin, and now you will inject that into the uterus below the interstitial pregnancy. Okay, this is very good for hemostasis. Number 3 is you can do the dilatation and evacuation with ultrasound guided using the polypectomy forceps. Okay, interstitial pregnancy, dilatation, evacuation, ultrasound guided using polypectomy forceps, and followed by single dose systemic metho, and after that you are going to give the single dose systemic metho. It also has very good results. The non-surgical technique includes, it's not very happening because it has an uncertainty regarding the safety and the complication of the future pregnancy. It's basically selective uterine artery embolization with metho. But for future pregnancies, for fertility concerns, it's uncertain. And in the 5th technique, or in the 5th point, is that a case report, they have just told us that there was a case report of 12 weeks of interstitial pregnancy with failed systemic metho. They gave intraamniotic injection of etoposide, which is being used in the gestational trophoblastic disease treatment. It is topoisomerase 2 inhibitor. So intraamniotic injection etoposide was given, and interstitial pregnancy resolved. So these all are the methods of the interstitial pregnancy. How are we going to manage it? Now moving towards cornwall pregnancy. Cornwall pregnancy, its management is very straightforward, very simple, because we are simply going to excise the rudimentary horn either laparoscopically or laparotomy. Okay, because it will avoid the recurrence. But remember this thing, that we are here dealing with a congenitally abnormal uterus. There is a possibility of other uterine urinary tract anomalies associated with a unicornuate uterus. Okay, so here a technique is mentioned, which is that excision of the fibrous band. You have to excise the fibrous band that attaches the rudimentary horn to the unicornuate uterus. Okay, you are going to remove that fibrous band, okay, that attaches the rudimentary horn to the unicornuate uterus, with the removal of the rudimentary horn through the secondary port when you are performing laparoscopy. Ovarian pregnancy. We're not going to compare ovarian pregnancy with any other ectopic pregnancy. We're going to read it and study it isolatedly. There is no specific agreed ultrasound criteria, but the TVS findings are, again, we are going to make a triangle with empty uterus, wide echogenic ring with an internal anechoic area on the ovary. Okay, on the ovary there is a wide echogenic ring in which there is an internal anechoic area. And number 3 is that the sliding organ sign is negative. Okay, because it's not possible to separate the cystic structure or the gestational sac from the ovary on the gentle palpation, so the sliding organ sign is negative. Okay, these all are the things which we can see on the ultrasound. These are the ultrasound findings, TVS findings. One important thing is that it must be differentiated from different things, because it while you are doing a scan, you should differentiate it from the corpus luteum, corpus luteal cysts, tubal ectopic pregnancy stuck to the ovary, ovarian germ cell tumors, other ovarian pathologies. So you have to identify and distinguish separately from the suspected ovarian ectopic pregnancy. Okay, color Doppler will aid in the detection of the FCA within an ovary, and the ruptured ovarian ectopic pregnancy, you will see the complex echogenic adnexal mass, complex echogenic adnexal mass with free fluid in the POD. Okay, it will represent the ruptured ovarian ectopic pregnancy. Now, biochemical investigation, yes, you have to repeat the serum beta HCG in 48 hours, just like previous two. Only the beta HCG levels in which there was no role. Which pregnancy was it? It was a cesarean scar pregnancy. Okay. Definitive surgical management is preferred if the laparoscopy is required to make the diagnosis. Okay, if you are performing laparoscopy, then you should go for definitive surgical treatment. Okay, now systemic metho can be used to treat ovarian ectopic pregnancy when the risk of the surgery is high, or post-operatively in the absence of the persistent residual trophoblast or the persistently raised beta HCG. Okay, you can combine systemic metho with the surgical treatment, but isolatedly you cannot have it unless and until there is a very high risk of surgery. Okay, so with metho alone, failure rate is 40% in case of the ovarian ectopic pregnancy. So metho alone is not going to completely resolve this ectopic pregnancy, this ovarian pregnancy. Okay. Okay, one important thing is that removal of the gestational products when you are performing laparoscopically, you are going to remove the gestational product. There are two different methods. One is enucleation and the other one is wedge resection. These both are preferred ones. Enucleation of the products of conception are done bluntly from the ovary because it will minimize the damage to the surrounding ovarian tissue. It is the enucleation. Okay, and if it is a large ectopic mass, then you have to do the wedge rejection. Occasionally there would be the oophorectomy that would be required with the coexisting ipsilateral ovarian pathology or the excessive bleeding, and for the hemostasis you can achieve it with the electrocautery or the suturing. So this is all about ovarian pregnancy. Moving forward towards abdominal pregnancy and the heterotopic pregnancy, these two are left. Heterotopic pregnancy, we'll talk about it after abdominal pregnancy. Now coming to the abdominal pregnancy, it also has a very beautiful ultrasound criteria. So we are going to divide abdominal pregnancy into an early abdominal pregnancy and the advanced abdominal pregnancy. Okay, early abdominal pregnancy, this is the these 4 points make a square, and on each corner of the square write these 4 points which are the diagnostic of this early abdominal pregnancy. There is no intrauterine gestational sac, there is no evident dilated tube or the complex adnexal mass. Number 3, gestational cavity surrounded by the loops of the bowel, and that's completely separate from the peritoneum. And the 4th point is wide mobility similar to the fluctuation of the sac. Okay, it is very fluctuating with the transvaginal probe. When you are when you are putting pressure on the transvaginal probe towards the posterior cul-de-sac, then there you will see the fluctuation of the gestational sac. There is a wide motility. Okay, So these four are the points of the early abdominal pregnancy, and you can make its diagnosis at laparoscopy during investigation for the persistently raised serum beta hCG levels. Patient has come to you with persistently raised serum beta hCG levels. There is no intrauterine pregnancy, there is no adnexal or the tubal pregnancy you are seeing, then you should consider for the abdominal pregnancy. You have to go for the laparoscopy, and if there is a high index of suspicion, it is based on the ultrasound findings and on the raised beta hCG levels. Okay, there's a high index of suspicion that is based on these both things. So advanced abdominal pregnancy, MRI is very important in advanced abdominal pregnancy, because that is very useful for the it is used as a diagnostic adjunct. Okay, it can help to plan. It will not only help to plan the surgical approach, this is all written over here. I'm just made the points and I'm just telling you that MRI will help to plan surgical approach. It will map precisely the location of the placenta before the laparotomy to avoid incising the placenta and the associated risks of hemorrhage. It will confirm diagnosis and identify the placental implantation over the vital organs, and it will help to guide the perioperative considerations. So basically there are 4 points that need to be figured out with MRI. It will help to plan the surgical approach. Location of the placenta will be mapped out before laparotomy, and diagnosis would be confirmed, and we'll identify the placental implantation, not only the location but also the implantation, and it will help us to guide perioperative considerations, surgical team, blood products, pre-op angiographic mobilization, bowel preparation, insertion of the urethral catheters will get prepared, okay, before laparotomy. So the management, moving on to the management for early abdominal pregnancy, it's always the laparoscopic removal. Okay, early abdominal pregnancy, it's the laparoscopic removal, and the alternative is that we can go for the systemic metho with the ultrasound guided fetocide and the systemic metho. These both are, we have options for the early ectopic pregnancy, but for advanced abdominal pregnancy we always have to go for the laparotomy. Okay, we're going for laparotomy. So in case of the early abdominal pregnancy, the diagnosis, if made very early, site of implantation is not involving the vascular area, then laparoscopic approach is very good, because it will not only reduce the blood loss, operative time, hospital stay, it will give us a very good results. And IM metho can also be given in a very few cases. IM metho was given with intrasecular injection of metho, and the success was very good. Now moving towards the management of the advanced abdominal pregnancy. It has a significant maternal mortality and morbidity. Morbidity is more, but mortality is reduced when we avoid the incision of the placenta. If there is placenta and we have a risk of incising it, then you should left it in situ if there is a vascular attachment. And then what will we do? We will wait for the spontaneous reabsorption. Okay, we'll wait for the spontaneous resorption. And preserving the placenta retention, it will increase the morbidity, because it will cause the peritonitis, hemorrhage, fistula formation, bowel obstruction, ileus. These all would be the complications, but the mortality would be reduced. Okay, so mortality would be higher if we had made an attempt to remove it. So moving on to the heterotopic pregnancy, I will tell you its ultrasound findings and biochemical investigation over here, and then when we will revise this in another lecture of about 15 minutes, you will get a whole review of this thing. Okay, so heterotopic pregnancy is always, we see it after artificial reproductive technique. Okay, ART. Patient has come to you after IVF, ICSI. Heterotopic pregnancy is a very high rate, and patient is complaining of persistent pelvic pain, persistently increased beta hCG levels following miscarriage and termination of pregnancy. So you should consider heterotopic pregnancy in the diagnosis. Okay, and the ultrasound findings, there is an intrauterine pregnancy with an coexisting ectopic pregnancy. Both pregnancies are there in the heterotopic pregnancies. Okay, and the biochemical investigation is a very, very, very limited role. So how are we going to manage it? Intrauterine pregnancy must be considered in the management plan. Okay, and metho is only considered if the intrauterine pregnancy is non-viable and woman is not in the favor of continuing the pregnancy. But in this case, if the woman is not wishing to continue, abortion act regulation will apply. Okay, now local injection of the potassium chloride will be given. Local injection of the potassium chloride into the fetal pole and the gestational sac would be given, or the hyperosmolar glucose into the extrauterine sac can be given with the aspiration of the sac contents. Okay, injection KCl locally into the fetal pole and the gestational sac, or the hyperosmolar glucose into the extrauterine sac, and you will aspirate all the contents, and you will only go for this procedure when the patient is clinically stable. And the next is the surgically removal. It should be the mode of choice for the hemodynamically unstable patients, and also it is an option for the hemodynamically stable patients. So the care should be taken at the time of the laparoscopy. You have to avoid the cannulation and the manipulation of the uterus. Okay, you have to avoid these things. And that local injection KCl and hyperosmolar glucose with the aspiration of the contents, it will minimize the risk to the coexisting intrauterine pregnancy by the surgical approach. Okay, but ultrasound follow-up is very important. It will ensure the resolution, and beta hCG is of no value because they do two pregnancies going on side by side. So expectant management is only for the ultrasound findings which are of non-viable pregnancy. Okay, then you can only think about the expectant management. When ultrasound findings are non-viable, then it is an only option. Okay, so we are done with all the ectopic pregnancies, and within 5 minutes we are done with this whole guideline. NTD prophylaxis has to be given to all the RHD negative women who have surgical removal of the ectopic pregnancy, or in which the bleeding was very heavy, repetitive, and associated with abdominal pain. Okay, following ectopic pregnancy, 25% of the cases of the ruptured ectopic pregnancy had alloimmunization associated with a significant number of fetal cells in the maternal circulation. Okay, so the alloimmunization was reported in 25% of the cases of the ectopic pregnancy, ruptured ectopic pregnancies. Long-term fertility prospects. Long-term fertility prospects, they are not very bad basically, as it seems to be that we have gone through the surgery, we have used the metho, so the patient is not going to conceive again. Long-term fertility prospects, there are five perspectives we have to see. Number one is the patient who has no history of subfertility, no history of tubal pathology. So any of this management method is not going to make any difference. Okay, there would be no difference in the fertility rate, in the future tubal ectopic pregnancy risk, in the tubal patency rate, everything would be same if the patient is not having anything in the past. Okay, healthy contralateral tube, healthy tubes. But if the patient has a history of subfertility, the treatment with the expectant and the medical management basically have improved reproductive outcomes, because the radical surgery is going to reduce the intrauterine pregnancy. Third is the metho. Metho management has no effect on the ovarian reserve. This is just a myth. Now a patient has gone through uterine artery embolization and the systemic metho for non-tubal ectopic pregnancy. In these patients, in the subsequent pregnancies, live births are reported. Okay, if there were 12 women in the trial who tried to conceive following the treatment, 83% of them conceived and 58% of them had live births. So it's not that bad. And at the last, the laparoscopic management of the ovarian ectopic pregnancy. 100% conceive, because the future fertility prospects were very good. We are just removing the pregnancy by the enucleation and wedge resection. We are not damaging the whole ovarian tissue. Support and counseling is very important, and in Pakistan it's a very neglected thing, because we don't have any support groups, we don't have any counseling sessions which are properly being done for these patients. So patients should be advised of the advantages and the disadvantages which is associated with each of the approach of the treatment you are using for the ectopic pregnancy. And the patient should fully participate in the selection of most appropriate treatment. It will create the curiosity and it will create the interest in the patients, and patient will not go into the psychiatric illness, she will not get depressed, she will not go into the post traumatic stress disorder. Number 2, you should make sure that the woman should be made aware of how to access the support through the patient support groups. Patient support groups are there in the UK, ectopic pregnancy trust, local bereavement counseling services. So you should make it sure that the patient is aware of them, and patient can get access to those groups. Muscle relaxation training is very important with metho treatment. Okay, and it is recommended that women should be advised and properly counseled that they should wait for at least 3 months before trying to conceive. These 3 months are 3 months window, because if the patient gets pregnant in these 3 months, major malformation rate is there in the pregnancy. Okay, so you have to tell the patient that you have to avoid the pregnancy for 3 months. Appropriate setting for the management of the woman with an ectopic pregnancy: 7-day early pregnancy assessment service. This is what early pregnancy care providers are doing. Okay, 7-day early pregnancy assessment service with the direct access for women referred by general practitioners and accident and emergency departments. Available facilities should be there for the suspected ectopic pregnancy to be managed. Okay, diagnostic, therapeutic algorithms, TVS and serum beta HCG levels. Women should have access to all the appropriate management options for the ectopic pregnancy. If local facilities do not provide all options, then clear referral pathways should exist to allow them to access appropriate care. Okay, this is all about the ectopic pregnancy. Um, Last thing is the training implications for the management of the woman with ectopic pregnancy. The clinicians who are undertaking the surgically managing the patient should receive the appropriate training. Laparoscopic surgery requires appropriate equipment and trained theatre staff. Clinicians undertaking ultrasound for the diagnosis should receive appropriate training. Undertaking medical management through ultrasound guided needle techniques should be appropriate receive appropriate training. Clinicians undertaking surgical management cannot carry out the full range of surgical procedures appropriately. Experienced support must be available if necessary. So virtual reality simulators can be used as a training tool for self-injectomy. This is all about the ectopic pregnancy. In the next lecture, I'm going to revise this whole big topic in a very precise way. Okay, thank you so much.